Thanks, Melanie. That was great, as always. I think we are going to have our Q&A session now. So I think we're maybe going to bring all three panel members up. That's great. So we've got one or two questions. If you do have questions, just fire them in the Q&A box because we still have time. We've got maybe just under 10 minutes before we go to our break. So Melanie, might come to you first. We have a question asking about SIPs and about what do you think the mechanism underlying the improved response to immunotherapy in folk who have a low score? I think it's a low score, isn't it?
Yeah, it's a low score.
Yeah.
They basically are fit patients. Yeah. And it comes back to the Glasgow story that's been around for many years of high CRP in lung cancer is very prognostic. You don't do well if you've got inflammation going on already. So CRP high. The difficulty with that scoring system, the Glasgow scoring system, was nobody measures CRP. So we couldn't apply it in a clinical way, whereas everybody gets an albumin done, everybody gets a neutrophil count. So this is to try and have something that is usable, easy to remember, instantly applicable in clinic, that you're able to say, and I now, when I'm treating patients with stage 4 non-small cell lung cancer, I look at the SIPs on them and think, okay, they're in that worst group, or this is in a group, they may do really well, and I tailor my conversation a little bit towards that. Doesn't mean they can't do well, but it just means we can give a little bit more accurate information how they personally might do. So it is about inflammation.
Melanie,
I'm sure.
Is it a prognostic only tool, or does it actually it doesn't predict response?
That's the next study. Is it predictive? Okay. Exactly. Is it prognostic or is it predictive? And what we're actually doing is we're going to apply it to a whole group of patients who only had supportive care only, and see, and that would be prognostic, and then look at patients who all got the same treatment and see. At the moment, it actually does appear to be both, is the initial data. And what's very interesting, it's also in stage 3 lung cancer, and it's also predictive in stage 1 lung cancer for SABR. So that's fascinating. I think that will run, and I want to see it in mesothelioma because I just think that's just a practical thing.
Yeah, I mean, it's the classic inflammation-driven cancer, totally. Isn't it? Mesothelioma, so it makes lots of sense. So Mavis Nye, who many of us know, has just chipped in to say that PD-L1 is not really proving to be the answer that we hoped, but I guess that spans all cancers in terms of immunotherapy. So I might come to you, Matt. So we've got a question about not so much about the audit data, but more about the pathway. So if there's been a prior diagnosis of pleural plaques documented, should that not flag up the possibility of meso? And if it's present, should it therefore allow us to avoid certain invasive investigations? So do you want to comment on that in terms of the pathway that we run?
Yeah, so obviously the presence of pleural plaques on imaging sort of draws attention to the fact that there has been asbestos exposure in the past, but we know that they're not a pre-malignant process. And so what we are looking for on imaging is more sort of specific signs of pleural malignancy or mesothelioma in particular, so pleural thickening and nodularity in particular. We do have our pathway in Glasgow is set up so that we can have access to sort of specific diagnostics if it looks like, based on imaging, that there is a higher likelihood of there being a pleural malignancy, and we can do direct to thoracoscopy in patients where it's highly likely based on their exposure history. They've been exposed to asbestos either through their recollection or the presence of plaques, and they've got a highly suggestive CT. They can go straight to what we hope would be a definitive diagnostic test. I think that there's a lot of people who have pleural plaques that are identified on imaging or even on chest X-ray who never go on to have any problems with pleural malignancy, and so think we can't categorise those as in the same group of patients. But what the pathway that we have in Glasgow and increasingly across Scotland is that we can identify the patients who are there is a high likelihood of there being a more sinister underlying problem, and diagnose them as early as possible while they're fit and sort of amenable to what treatments we have available.
Yeah. Okay. Yeah, I think that's absolutely right. So the plaques can, and some other features can help us stratify the pathway and maybe direct them down maybe a more efficient route with less tests. But by the same token, some patients who can have meso and don't have calcified plaques. So it's not completely straightforward. Melanie, I wanted to ask about, we've seen through COVID actually that you can deploy clinical trials really efficiently. We can deploy clinical trials across hundreds of centres and recruit thousands of patients really rapidly with quite a slim protocol and quite neat and quite lean. One of our goals obviously together is to try and allow patients from across Scotland to get the same access to trials. But how do we do that? Can we learn maybe from the experience in recovery, the recovery trial in COVID? What do you think in terms of us delivering that?
Yeah, I think trials have gone far too far the other way, and I am embarrassed to hand out patient information leaflets that are 35 pages long and cover every single side effect. They're not consent in my eyes if you are asking somebody to read all of that. It's not appropriate. And that's where it's come from. It's a lot of commercially driven trials, and they want a uniform population and a uniform answer. And it's not real world. And for too long, oncology, and I'm guilty as charged, as a medical oncologist, the funding by drug companies, without them, I wouldn't have been able to do half the things I've done. However, I think they've had the reins for too long. And we need to go back to real world. I didn't get a chance to talk about it, but the CARES trial I really like is a synthetic cannabinoid that we're doing a phase 1 on. And it's investigator driven. It is a sensible trial on patients losing weight and having broad entry criteria, and that most patients will fit the criteria and can have a go. And those sorts of trials are very important, but how they get funded, and it takes 10 years, I think, from you having an idea to getting it funded to getting it up and running. It's a long haul. I felt for Sanjay Poppet doing the PROMISE trial, because I know he'd been working on that for probably at least 8 years, and it was negative. It's really hard. Yeah.
Yeah, I think one of the issues, we'll maybe hear from Daniel Murphy later in the talk about some of the preclinical work to try and test maybe some simpler drugs, repurposing drugs that, like the recovery trial, the advantage there was that it was a repurposed drug. It was like steroids and simple drugs that we can use in open protocols. And if we had, that's certainly our intention through the Predict Meso Accelerator, is to try and use repurposed drugs and try and have candidates that we can deploy more efficiently in larger trials. So it's very difficult. Okay, so we've maybe got 1 minute. Matt, I think the most striking thing I think that we all get excited about is when we see survival differences in data. And so your work is when you were very honest in your appraisal of the limitations of cohorts that come pre and post an intervention, and it's not a randomized trial. But what do you think? Obviously, the evidence base for MDTs is light, isn't it? And how we make the case in other parts of the world that you should have an MDT and you should have a network approach. What do you think? Where do we take that data, and how much do you believe in it, and what are the kind of gaps that you think exist?
So there is some but scant data that MDTs improve survival in other cancers, and you'd like to think that the same is true in mesothelioma. And obviously, having an MDT is really, I guess, a proxy for doing lots of different things well, and so diagnosis and staging and getting people access to treatment and trials, all of which is sort of part of the remit of the mesothelioma MDT. So measuring the intervention of an MDT is really measuring all of those things, or the sum total of all those things. The slides I showed, which were sort of survival curves, are I guess quite simplistic because they're not measuring the effect of heterogeneity of the populations. And that's something, like I mentioned, I'm trying to create some more sort of representative models which take those things into account, and to see if there is still a difference there, which I would hope to see. And I think that just requires, again, sort of more data is just helps refine that. So there's now probably 6 months more of national MDT data since I sort of last kind of collected everything and put it into those models. And then there's going to be more PHS kind of nationally collected data coming online in the next couple of weeks, which again can feed into that. So there's some tightening up to do, but I'm hoping that that sort of demonstrable improvement in survival with the intervention kind of holds once you've corrected and taken into account newer data.
Can I just comment? What I have seen, though, as well, is that the pathway to diagnosis has been dramatically shortened with mesothelioma over the last 10 years. It used to be you would have these patients going for ages until we actually got a diagnosis. It was horrible. Have we any information about lag time? Is the survival because we're just diagnosing quicker?
That's possible, yeah. So that's something that I'm looking into at the moment. The sort of the time gaps between imaging and diagnosis or biopsy and then in diagnosis. Yeah, so that's another effect, a variable which needs to be kind of corrected for, I suppose. But you're right. That there's a potential impact there.
It's striking how good the process is wonderful.
Yeah, I mean, it's certainly very noticeable in the data that actually so many of our patients are early stage. We talk about immunotherapy and all these drugs, which actually are for technically non-resectable patients, but actually we've got, I think 60% of our patients are stage 1 and 2. So actually we've got a really big gap there of what we do with technically resectable disease in an evidence-based way, and that might talk to an earlier diagnosis, but I'm sure Matt's further work will fill in some gaps.
Yeah.
Now we're out of time, unfortunately. What do you go, Matt?
I'm hoping by essentially looking, these are patients who are diagnosed with mesothelioma, and then sort of looking back at the date that you could have retrospectively said that they had mesothelioma or suspected. So it's kind of does remove some of that the diagnostic lag potential, but it remains to see if that holds up.
Okay, so that was a really good discussion. Just want to thank Melanie and Matt for their contributions. I hope that was enjoyable. We've run over by a few minutes, so we were due to come back. We were going to have a 15-minute break, I think, and we were going to come back at 2:25 Now, a 5-minute break seems a bit harsh, so why don't we have a 10-minute break, and we'll aim to restart the next session at 2:30. And in the gap, we're going to have an animation summarising the GEMS study, I think. But thank you to the speakers.